This video is about the use of the preformed iGen titanium membrane, osteogen plug and porose and infuse, which is recombinate BMP2 made by Medtronic. This is a case of a young female patient with a congenitally missing lower left lateral incisor. The first step is to take an impression and pour it up in orthodontic plaster or scan the arch and have a solid model printed. The next step is to drill a hole with a 3/32 drill at the proposed implant site. It may not be perfect and often will have to be corrected and either moved bodily or the angle changed after evaluating the diagnostic guide with the cone beam X-ray. Do not over-drill it and make the hole larger than the drill or the resulting guide will not be accurate. Next, place a 3 mm guide post in the hole in the cast and place a 3 mm guide sleeve on it with the cleat positioned lingually. Apply Premotec gel to the cleat, cure it for 20 seconds, lubricate the cast or model. Then add Premotec splint material to the lingual surface of the anterior teeth, extending back to the first molar on one side of the arch. Do not extend it to both sides of the arch, or you will not be able to remove the diagnostic guide from the cast because of the undercuts. These are the steps to make a non-printed laboratory-corrected surgical guide. The first step is to make the diagnostic guide. Next, take a cone beam X-ray with the diagnostic guide placed in the patient. Then evaluate the CT images of the long axis of the 3 mm cylinder and place a virtual implant in the ideal position. Compare the long axis of the virtual implant with the long axis of the guide sleeve. Check both the angle and linear position of both the diagnostic guide sleeve and the virtual implant. In both planes, mesio-distal and bucco-lingual. If necessary, correct both angular and linear position in both planes. By using a straight or offset guidepost and correcting the angle of the two-piece guidepost, the angle corrections are made with the bending tool. Then make the surgical guide. While it is not necessary, you may choose to verify the corrections. Take another CT until you are confident the guide is correct. Then you may, with or without reflecting a flap, place the implant. This is the evaluation of the diagnostic guide with a 2.9 mm virtual implant. It is located in the position I preferred. You may prefer the implant to be placed in another position, for example, placed farther lingual, deeper, or placed at a different angle. In that case, it has to be corrected and another surgical guide has to be made. The cone beam evaluation of the case indicates there is a void on the bucco surface that will need augmentation prior to implant placement. The proposed grafting is shown beneath the yellow line on the image on the right. The grafting materials include a dry osteogen 10 by 20 mm plug, cut in 3 pieces, and 50 micrograms of infuse, known as BMP2, made by Medtronic, and 0.3 milliliters of sterile water. The pieces of osteogen saturated with the BMP2 are placed in an open vial of 1 cubic centimeter of porose. For a time period of 15 minutes for the BMP to adsorb onto the porose particles. The iGen titanium mesh, size 1A, is shown being positioned on the cast and contoured to the surface prior to the surgery. A full thickness flap is reflected and small holes are drilled in the facial plate to access the marrow space. An 8 mm tenting screw with 5 mm exposed is placed in the bone to hold the titanium membrane out and make room for the graft material, which will be placed below it. The graft material is placed around the exposed screw and the membrane will be placed over the graft. The A1 iGen membrane is positioned over the graft and a 3 mm screw secures the top to the bone to immobilize the membrane. Bucco and lingual flaps are closed over the titanium membrane, with primary closure if possible, even with a periosteal releasing incision. In this case, it was not possible. Nylon sutures were used to close the flaps as close as possible. The 3 mm stabilization screw remained partially exposed for the entire 4-month healing period. After 4 months, a new impression was taken. You can see from the occlusal view that, clinically, the alveolar crest appears wider than it was prior to the augmentation. The 3 mm screw remains visible on the lingual surface. The next step is to evaluate the images of the 3 mm diagnostic guide sleeve and the cone beam images of the software program to determine if the position of the guide sleeve is satisfactory. The facial view of the cone beam X-ray reveals the presence of the tinting screw, and it shows the alignment of the 3 mm guide sleeve between the two adjacent teeth is satisfactory and does not need angle correction mesio-distally. The cross-section view shows the titanium mesh on the buccal surface, the tinting screw, and the 3 mm screw at the top of the membrane. There also is evidence of mineralization of the graft material beneath the membrane. Notice that the implant is not aligned with the long axis of the guide sleeve. In fact, it is measured and it is 0.7 mm offset from the long axis of the center of the guide sleeve. We have to choose between 0.5 mm and a 1.0 mm offset guidepost to correct the position. So we are choosing the 0.5 mm offset guidepost to make the correction. Now we're ready to fabricate the surgical guide with a 0.5 mm offset two-piece guidepost with a 3 mm top part and a 3 mm guide sleeve. Post is inserted into the hole in the cast. With a 3 mm top part, a 3 mm guide sleeve is positioned on it with the cleat rotated to the lingual surface. Next, we're going to reflect a full thickness flap. Remove the 3 mm screw, the titanium mesh, which leaves the 8 mm tinning screw top exposed. The 8 mm tinning screw is removed as well. The surgical guide is placed, and in this case, a 1.6 mm guide sleeve insert is placed in the 3 mm guide sleeve to enable to start with a Strawman 1.5 mm starting drill. This picture illustrates the placement of the 2.3 mm drill and the 2.5 mm guide sleeve insert. A Strawman 2.8 mm drill is used next within the 3 mm guide sleeve. It is not shown, and then the implant can be placed. The cover screw is placed, the flap is closed, and the temporary partial is placed back in the patient. To verify the accuracy of placement mesio-distally, a post-surgical periapical X-ray was taken. After viewing the periapical X-ray, the Strawman explantation tool was used to position the implant a couple of millimeters deeper, at least 3 mm below the adjacent CEJs. This is the cross-sectional view in a cone beam image indicating the placement of the implant in a bucco-lingual plane. We have changed the protocol since then using a 3 mm guide sleeve and the Deplaque 3 mm depth stop Lindemann drill series. The 3 mm Lindemann drills cut both at the apex and on the sides, preventing the anterior drill deflection we have often noticed because of the deflection of the typical twist drills by the cortical bone of the lingual plate. Using a series of 3 mm Lindemann depth stop drills to the depth that is required reduces the need for multiple guide sleeve inserts.